This is the last set of slides for all the antibacterial sessions that we did. We did before that the aminoglycosides, inhibitor of translation, and now we're going to move to the non-aminoglycosides. We have seen this table before showing the drugs that are ribosomal inhibitors, and we already talked about aminoglycosides, and now we're going to talk about tetracycline, linezolid, chloramphenicol, clindamycin, and macrolides. And I want you to remember that the ones that we are discussing from now on are bacteriostatic. Remember that aminoglycosides were bactericidal. And where are we? So we did aminoglycosides last time. They were only 4 gram negative. Now we're gonna move here and notice a very important point, and that is now we are starting to cover atypical bacteria. For instance, tetracycline, chloramphenicol, and macrolides cover atypical bacteria. Let's start with the first class, and that is the tetracycline. So why is it called tetracycline? Obviously, you can see here 4 cycles. And of course, I don't want you to remember the structure, but note that when we have changes over here, we lead to some pharmacokinetic changes. And also, usually when you see an antimicrobial that finishes with cycline, 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 typically it is one of the tetracyclines. Mechanism of action, we are still at the small subunit at the 30S. Remember, aminoglycosides also inhibit this 30S. And here what's happening is that tetracycline is inhibiting the binding of the amino acid transfer RNA to the acceptor site. And it's doing that by binding to the 16S ribosomal RNA as well. Selective toxicity, it's obvious to us. Yes, we do have ribosomes, but tetracyclines do not work on our ribosome. Unfortunately, we do have resistance, and the 3 main mechanisms that were proven for tetracycline are decreased influx or increased efflux, and the most common being decreased influx. Also, we have production of a ribosomal protection protein that displaces tetracycline, and we may also have enzymatic inactivation, just like, you know, beta-lactams and aminoglycosides. I haven't explained anything. I'm putting this question before I explain. So how about you try? So we have 2 tetracyclines, doxycycline and tetracycline. And doxycycline has a high lipid solubility, whereas tetracycline has a low lipid solubility. So what do you think? Okay, let me put the answer. Yep, so tetracycline is probably more affected by kidney disease. Well, why is that? So what did we say here? We said that doxycycline is lipid soluble. So if doxycycline is lipid soluble, we expect it to be more orally absorbed, not tetracycline but doxycycline itself, because of the permeability by diffusion. Because it is highly lipid soluble, doxycycline, we expect it to be more metabolized in the liver when compared to tetracycline, and hence we expect tetracycline to be excreted in the kidney as is, more or less. So we expect tetracycline to be more affected by kidney disease. And here's a table showing what I just mentioned. So we have tetracycline here and doxycycline here. So tetracycline has low lipid solubility, and hence I expect a lesser absorption orally when compared to doxycycline. I expect some effect with food. Why? Because it's sitting there instead of being absorbed quite quickly. So yeah, there is some food interaction, and I would expect the elimination route to be more renal than hepatic, and hence if the patient is anuric, meaning that the patient has kidney disease, I would expect the half-life to increase much more with tetracycline when compared to doxycycline. And we have demeclocycline in the middle. Pharmacokinetics. So we do have both orally bioavailable formulations and IV. But for the orally ones, we have to be careful, and this is super important because absorption is impaired by milk, antacid, iron, and zinc. So what do you see common here? Milk, calcium, antacid, aluminum, iron, and zinc. So I'm talking about cations. It turns out that tetracyclines chelate those cations, and hence they impair their absorption. So it's very important, if you prescribe a tetracycline to a patient, you tell your patient, well, you know what, if you want to take it in the morning, don't take it with your Nescafe that has milk. Or you know what, if you take your iron in the morning, don't take it with your iron. There should be space by at least 2 hours. There is a wide distribution, but I want to point out two things here, and let's see if you guess what I'm pointing to. So one, there's deposition with calcium in bone and animal of non-erupted teeth. 2, it crosses the placenta. 3, elimination, in addition to renal and biliary as we saw in the previous table, also we can see tetracycline in the milk. So I guess now you guess what I'm alluding to. Maybe we don't want a pregnant woman to take tetracycline because that would affect maybe the bone of the baby. Maybe it's going to affect the teeth. You don't want to be lactating because that would affect the baby. Yeah, that's true. Let's see that in the next slide. So to continue our line of thought, I'm going to read here. So what happens is that tetracycline again is going to bind to calcium, and we're going to have deposition of tetracycline calcium orthophosphate, which is no big deal. However, when there's exposure to sun, and obviously the teeth are exposed to sun, we're going to have some dark bands on the teeth, and those are irreversible. So remember, we have the deciduous teeth and the permanent teeth. The deciduous teeth usually appear after 4 months of gestation. So a pregnant woman, the fetus would have some teeth and they would be affected, and the permanent teeth would appear 4 months after birth to 8 years. So really, if I want to be on the safe side, I would not give tetracycline before 8 years of age when I'm sure that the teeth are well formed. Concerning bone formation, there might be some problem, but not as much as teeth. Additional adverse effects, gastrointestinal, most common. Remember, if we know nothing about antimicrobials, we just put GI side effect. We already said that we want to take it with food, but not milk. Why do I want to take it with food? Because again, some of them, like tetracycline, remember we said tetracycline stays more in the GI system, so there will be more interaction with food. Not more interaction with food. What I meant here is that you want to take it with food so that hopefully you have less gastrointestinal side effects. Apologies for this confusion. But not milk, right? Because it will chelate the milk. Doxycycline is the least associated with gastrointestinal side effects. And pseudomembranous colitis, the super infection example. Remember, pseudomembranous colitis can happen with any antimicrobial, and we said it happens more with the broad spectrum and combination, but there are some antimicrobials that are associated a little bit more with pseudomembranous colitis, and tetracycline is one of them. There's also photosensitivity, so you want to tell your patient to take sunscreen, to put sunscreen, and also there's a risk of thrombophlebitis with IV administration, and we saw that side effects with other antimicrobial. Obviously, this is when you take it as IV. And here's a picture showing those dirty teeth, and I don't know if you can see those dark bands. Well, those dark bands are not dirt, those are the darked band because of the tetracycline deposition. What's the spectrum of activity? Originally, they were amazing. They were broad spectrum. Aerobic, anaerobic, gram positive, gram negative. But now, unfortunately, we have a lot of resistance and we do have better antimicrobials. Now, you ask me which are better antimicrobials. You should know by now. We have already learned a lot. Penicillins, cephalosporins, quinolones, we talked about, and there's more also coming up. However, it is now reserved for atypical organisms. And here's the spectrum of activity again, so we really keep them for atypical microorganisms. We're done with tetracyclines. Now we move to linezolid, and from now on we're moving to the large subunit. And actually, linezolid has a very special mechanism of action. It actually inhibits the initiation complex, and if you watch that YouTube movie that I pointed to you, then you can remember how the 30S and the 50S attach to each other to have the initiation complex. More specifically, what does linezolid do? Well, it inhibits the binding of methionine transfer RNA into the 23S ribosomal RNA at the 50S site. And hence, by that, this will lead to inhibition of the formation of the initiation complex. Resistance. This is a unique mechanism of action, no cross-resistance. What do I mean by this sentence? So far, in its class, there is only linezolid. So if we have resistance to linezolid, it's only resistance to linezolid because there are no drugs in the same class. Remember we talked about aminoglycosides, for example, and we showed at least 4 in one of those slides, and then there might be cross-resistance. Also the beta-lactams, you may have cross-resistance. Here it's really a unique mechanism of action. There are no drugs that have the same mechanism of action. Luckily, so far, it's difficult to occur because we have multiple copies of the 23S ribosomal RNA genes in bacteria. Selective toxicity. This is becoming repetitive, but it's okay. Linezolid does not bind to our larger ATS ribosomal subunits. Some killing characteristics, we already said that it is bacteriostatic. We said that the ribosomal inhibitors that we're taking together, aminoglycosides, are bactericidal and the rest are bacteriostatic. Except for strep pneumonia, it is cidal because of autolysin activation. We do have a post-antibiotic effect, and here we have a time-dependent killing. You're gonna ask me, but doctor, you've been explaining to us that when an antimicrobial works inside the cell, then it is concentration-dependent killing. You're right, here it is a time-dependent killing, and to be honest, I'm not sure exactly why. The spectrum of activity, it is for the worst of the worst resistant gram-positive organisms. And who are we talking about? We're talking about VRE and vancomycin-resistant staph. Linezolid does work for other gram-positives. It doesn't have to be VRE. It doesn't have to be vancomycin-resistant staph. It could be MRSA, but I really don't want to give linezolid to MRSA. For MRSA, we decided we want to give vancomycin or 5th generation cephalosporin. I keep this for VRE. And here we go. We look at the spectrum of activity. You see quite a lot of gram-positive coverage, just like vancomycin here, but specifically for VRE. Obviously here I do not have atypical coverage. So far only tetracyclines in this voiceover PowerPoint. Adverse effects, some minor headache, nausea, diarrhea. Again, we could have hypotension, myelosuppression, but most important, I want to point out that actually linezolid was initially developed to be a MAO inhibitor. You have not taken MAO inhibition yet in psychiatry, but MAO inhibitors are antidepressants, and I'm going to show you in the next slide that we have to be careful with those drugs. One, if we take them with other antidepressants such as selective serotonin reuptake inhibitors, SSRIs, we may have hypertension, etc. And also you want to be careful with the food that contains tyramine. What are the foods that contain tyramine? It's things like red wine, old cheese, Roquefort, and some jams, if you're not really jams, like dried figs, etc. So your patient, you don't want that person to be taking a tyramine food. Now also you would tell me about the patient is in the hospital, and eating the food of the hospital, but you know, many times visitors do bring some food and you never know what kind of food you bring. So here we go. Here let's focus on the left side of the slide. Norepinephrine is typically metabolized by MAO, monoamine oxidase, here in the sympathetic neuron, so that we don't have hypertension. Also, tyramine that we can get from some foods is also metabolized by another MAO in the liver, so we're good. Now, if a patient is taking a MAO inhibitor, so we have an X here and X here, what would happen with the MAO inhibitor? We have norepinephrine is not metabolized, and hence it is available to be released, right? But we don't necessarily have a hypertensive crisis. We would have a hypertensive crisis with the addition of tyramine, because tyramine will not be metabolized. And what does tyramine do? It's written here. It promotes release of norepinephrine from the sympathetic neuron. So we have norepinephrine, it's not metabolized, and tyramine is promoting its release, and hence we would have a hypertensive crisis. We're done so far with tetracycline and linezolid. Now we move to chloramphenicol. Chloramphenicol is not available in the market, but it's important to mention it. This drug is associated with very serious and fatal blood dyscrasias, anemia specifically, and potentially aplastic anemia. It's really bad, really toxic. Now we keep it for serious infections such as meningitis in case of resistance or allergy to penicillins or cephalosporins. If we're stuck, although it's not available in the market, but suppose it is, and we're stuck with serious infections such as meningitis, we cannot give penicillin or any other beta-lactam, then we may consider chloramphenicol. Mechanism of action, we are now at the 50S, and what chloramphenicol is doing, it is inhibiting the peptidyl transferase activity. It's working here. It's competitively inhibiting the binding of the amino acid containing end of the transfer RNA to the A site on the 50S ribosomal subunit, so we inhibit the peptide bond formation. Selective toxicity, again, it's becoming repetitive, but it's okay. It does not bind to our ribosomal subunit. It does not inhibit our peptidyl transferase. However, it may bind and inhibit our mitochondrial peptidyl transferase, and this is the reason why we have this toxicity. Resistance, we do have inactivation via acetylation, decreased permeability, and ribosomal inactivation. This drug is given orally and IV, and why am I putting this information here? Because it's kind of interesting. So it does have an excellent oral absorption, however it does taste very bad, and you would tell me, okay, who cares if it tastes bad? Well, We adults don't care much, but if we're dealing with a child, and children would not take a drug that tastes bad, and you are dealing with an antimicrobial, you want to make sure you have good compliance and they won't take it. So we do have an oral formulation, which is a palmitate ester that tastes better, and we also have an IV formulation that is succinate ester, so that it is given IV. Distribution, wide intracellular, CSF, you guessed that. This is a drug that has an excellent distribution in the CSF, and hence we can use it for meningitis. And it is metabolized, glucuronidated. And now you ask me why? Because this is important in a newborn. If we may have toxicity in newborn where the phase 2 enzymes will not be as active. And it's coming in a few slides from here. So what does it cover? We said that this is good for meningitis, right? So you would think of strep or Neisseria. So we have some gram-positive and gram-negative coverage. Also, by the way, we have some anaerobic and even atypical. But we don't really care much here because we have others for anaerobes, and they won't be as serious as meningitis, remember. So we really focus here for meningitis. So here's a repetition of what I just said. It's good for strep, Neisseria meningitis, Haemophilus influenza, other gram-negatives, many anaerobes, and even atypical, but we keep it for CNS infection. Again, it is bacteriostatic. So what is this toxicity that we don't like? We do have bone marrow suppression. Luckily, it's transient. It's dose related and plasma level related, and it's reversible. So this is okay, although all bone marrow elements could be affected, but it's okay. And why is that happening? Possibly due to inhibition of mitochondrial protein synthesis, as we said before. But the problem is aplastic anemia. Aplastic anemia يعني zero red blood cells, no more red blood cells at all. And the problem with this is that it's not dose related, not plasma related, not time related, it is irreversible, it is super rare. But if it happens, it's often fatal, and if the person recovers, potentially the person is going to have acute leukemia. I don't want to take this drug. I don't want to give this drug to my patient. However, if I have to, because meningitis also kills, then maybe you could give it. And in newborns, the gray baby syndrome, I briefly mentioned before that the drug is glucuroninated, and then if a baby has a developmental deficiency in the enzyme or maybe in the transporter, then that baby would have very high plasma levels of the drug despite using a regular dose. So that could happen in premature babies that have this developmental deficiency. And why is the baby called gray baby? Because the baby is cyanotic, and potentially we can have death. Other toxicity, GI side effect, cytochrome P450 interactions, and this is important, and you're gonna see CYP interactions as well with the last class that we will discuss in a minute, and that is macrolide. And optic neuritis also could happen, maybe reversible, maybe permanent. The last two we have now are clindamycin and macrolides. So clindamycin, similarly to chloramphenicol, we have PO and IV formulation. The PO tastes better, and the IV can be given IV. Mechanism of action, we are still at the 50S and also peptidyl transferase, but here at the A and P site, a little bit more to the left if you want. For selective toxicity, well, this is again becoming repetitive, but it's okay. Clindamycin does not bind to our larger ribosomal subunits, no inhibition of our peptidyl transferase. So far, luckily, resistance is seldom a clinical problem. It is orally absorbed. We already discussed that we have an oral form and an IV form. Distribution, CNS, not that good. So if you have a patient with meningitis, definitely clindamycin won't be good. And however, it does go nicely to alveolar macrophages, PMNs, and abscesses. And actually, you see here the spectrum of activity. Although it's useful for gram-positive bacteria, really we think of clindamycin when we are dealing with anaerobes, especially Bacteroides fragilis. And obviously it is bacteriostatic, we have already agreed on this. And if we look here at the spectrum of activity, fine, we do have some gram-positive coverage, but we are mainly interested in anaerobic coverage here. Toxicity, pseudomembranous colitis. We talked about it, we see it with everyone, but if you want to ask yourself which antimicrobial is notoriously associated with pseudomembranous colitis, and that is clindamycin. And finally here I have a slide specially for it, explaining exactly what's happening. So the unabsorbed drug would alter the gut flora, and hence we have secondary overgrowth of Clostridium difficile, and then we have exotoxin, and that exotoxin will lead to diarrhea and pseudomembranous colitis. The treatment, the first line is vancomycin PO. We mentioned that before, and you can also treat with metronidazole, flagyl. Metronidazole can be given both IV or PO for pseudomembranous colitis. Finally, macrolides, and I'm showing you here 3 macrolides: clarithromycin, azithromycin, and erythromycin. There are some differences in the structure that lead to differences in the pharmacokinetics, being acid stability, tissue penetration, and the spectrum of activity. The mechanism of action, we are at the 50S, and here we are inhibiting the movement of a new peptidyl transfer RNA from the A site to the P site. So you can see that macrolides and clindamycin and chloramphenicol, they work on similar areas, but not exactly the same place, of course. So they do not really inhibit each other. It is bacteriostatic, we already mentioned that. Selective toxicity, we have macrolides, again this is repetitive, they do not bind to our larger ribosomal subunit, and there is no inhibition of our eukaryotic protein synthesis. Resistance is really becoming a problem. What are the most cited mechanisms for that? Drug hydrolysis, so enzymatic modification, efflux pumps, ribosomal protection, and obviously we would have cross resistance among macrolides. I showed you at least 3 macrolides. Spectrum of activity, there is some nice coverage for gram positives. However, we think of macrolides specifically for the atypical organisms, and this is the time when I mentioned them, but I'm sure that you took them already. So we think of Mycoplasma pneumonia, we mentioned that with quinolones, and also you can think of chlamydia trachoma, and that is in sexually transmitted disease. And here's the spectrum of activity: gram positive and atypical. I put this slide not for your memory, but take some differences between the 3 macrolides and also other pharmacokinetic details for the macrolides, because those are commonly used drugs. But I want you to point out that it doesn't distribute in the brain, so definitely not for meningitis. Toxicity, they are usually safe. Nausea and vomiting, again, there might be an increase of QT interval. We've seen that before with fluoroquinolones and CYP interaction, and we've seen that also, remember, with chloramphenicol. And I believe this is the last slide showing the site specificity of the ribosomal inhibitors. We talked about aminoglycoside, tetracycline, linezolid, clindamycin, chloramphenicol, and erythromycin. The first two are on the 30S, the others on the 50S. The first one is cidal, all the others are static. And here you have the mechanism of action that we mentioned before and pointed out in the figure here.